Good afternoon. It's good to be with you today for the EEG course. Now, most of this course has focused on basic EEG principles and interpretation, but as we all know, the COVID-19 pandemic has affected practically every aspect of medicine, including the practice of EEG. So in this brief session, we're going to start with a review of the EEG findings that have been reported in COVID patients, but we're going to spend the majority of our time on how to safely and appropriately perform EEGs during this current pandemic, including appropriate screening and triage of patients, how to minimize time in the patient room, and when we're in the patient room, how to reduce the risk of transmission. And if you recall, the last major pandemic was in 1918, which was prior to the introduction of EEG in the 1920s. So these issues of EEG safety weren't relevant during the last pandemic. So first, what do we know about EEG findings in COVID-positive patients? Well, this is a series of some of the first series that were published in late April and early May, up through the beginning of September, which is when these slides had to be submitted for review. Now, no doubt over the next few months there will be likely other series published. And so if we look at a summary of the findings, we find that it's quite an international representation with reports out of New York, Paris, the United Kingdom, Italy, and Cleveland. But you'll see that the majority of these are relatively small series, and these findings are based predominantly on routine EEG recordings. There were very few patients in these early series undergoing continuous EEG monitoring. Most of the findings were generalized or nonspecific, although there were some patients reported to have periodic discharges, including epileptiform discharges, and a couple of patients were reported to experience seizures. But then more recently, in early September, this large series was published out of New York. This series looked at 111 patients, and they were all undergoing continuous EEG monitoring at New York University. The majority of these patients were critically ill and in the intensive care unit. Now, similar to the prior reports, the majority of these patients were noted to have generalized slowing, but about a third of them were noted to have sporadic or periodic discharges, and there were electrographic seizures in 7%. Now, if you compare these findings to prior series of patients undergoing EEG monitoring in the medical ICU, you find similar findings. We know that seizures and periodic discharges are not nearly as common in our medical ICU patients as in our neuro ICU population, but they're certainly not rare. So we really need to be able to perform EEG studies in this patient population. However, surveys that queried members of the American Epilepsy Society and also the Critical Care EEG Monitoring Research Consortium found that, at least during the spring and summer, overall EEG volumes were markedly reduced. So let's talk about EEG safety, starting with screening and triage of outpatient procedures. So if you have a patient who's COVID positive or a patient under investigation, it obviously would make sense to postpone a routine outpatient procedure until that patient has recovered. But even for COVID negative patients or asymptomatic patients, consider the clinical impact of the diagnostic information you may get from a routine EEG. For example, if you have a patient with a confirmed diagnosis and a management plan in place, then you might consider postponing that routine EEG. Now, all patients that show up to our outpatient clinics, our EEG labs, are going to undergo symptom screening, but you can also consider screening these patients a day or two prior to their procedure to ensure that you don't have patients showing up the day of their study with COVID symptoms. And then finally, if you have patients that you know need an in-person visit, such as a new patient referral, but also could benefit from an outpatient EEG, they consider scheduling the EEG on the same day as the in-person visit. This not only reduces exposure for the patient, but also reduces exposure for our staff as well. So how can we make our epilepsy monitoring units safer? I know that most of us shut down for at least part of the spring and early summer, But by now, most of us have opened back up, at least in part, and this is largely due to patient demand. So first, consider whether home monitoring or an ambulatory EEG has a reasonable chance of capturing the data and the information we need. Or even of simply obtaining a home video of a typical event, whether or not that would be enough diagnostic information. Again, for our diagnostic patients referred to the EMU, consider first whether they've adequately failed an empiric treatment trial before automatic referral. And then for our surgical patients, I think it's important to assess the urgency of the pre-surgical admission and subsequent surgery by looking at the disease burden and how much their seizures are influencing the patient's quality of life. And think about the potential impact of a surgical intervention and how a surgery could reduce the risk of injury or possibly SUDEP. And finally, I think it's helpful to gauge the willingness of the patient to actually come in for an inpatient procedure. I found that during these uncertain times, some patients have become a lot more reticent to come into the hospital for monitoring. So it's helpful to have that discussion with how comfortable the patient is in proceeding before referring to the epilepsy monitoring unit. So once the decision's been made to proceed with EEG monitoring, first and foremost, if pre-admit COVID testing is available and test results returned in a reasonable time frame prior to admission, then by all means, COVID testing should be considered as part of our routine EMU protocol. Now, admittedly, not all institutions have access to pre-admit testing or may limit pre-admit testing to certain populations considered to be high risk. So if testing is not available, consider an enhanced screening protocol. So at our institution, our epilepsy coordinator reviews a COVID symptom list with the patient when they're scheduled, and again 2 to 3 days prior to admission, in addition to the screening that all patients undergo when they enter the hospital. In addition, consider self-quarantine for 10 to 14 days prior to the admission for both patients and families. And if you're going to do this, it's important to educate our patients and families on exactly what that means to self-quarantine. At our hospital, we are following a similar protocol to what our OB service has instituted regarding self-quarantine for their planned deliveries. And finally, we need to manage visitation and caregivers. Now, pretty much all of our hospitals have visitation policies that are currently restricting visitation, but it's important to recognize that having a caregiver or family member present can be essential in the EMU, not just for safety, but for accuracy and recognizing a typical event. So it's important to plan ahead and know which patients will require a caregiver to be present and to explain what that means to the caregiver as far as their own personal safety and what is expected of them. Now, admittedly, one of our biggest challenges has been in developing EEG safety protocols for inpatient studies. For patients under investigation, it's really important to know your institution's testing turnaround time. If you know that reliably you get COVID test results within 1 to 2 hours, then for all the non-urgent EEGs, you should strongly consider postponing that until the test results are available. If the test is negative, then that not only markedly reduces your use of PPE, but also reduces your technologist's anxiety about going into the room for the study. Now, for our COVID positive patients, consider a protocol whereby an EEG attending or tech supervisor reviews each individual EEG order for the necessity of the study, but also so that they can prioritize high-risk patients, such as those with status epilepticus or in coma with prior clinical seizures or undergoing hypothermia for cardiac arrest. And having a triage protocol can also avoid duplicate procedures. So we often get a request for a routine EEG that may come from the hospitalist service, but on review of the patient's history, we recognize that a continuous EEG study is probably going to be more appropriate for that patient. And so we'll go ahead and change the order to a continuous EEG to avoid duplicate studies of a routine followed by a continuous later. So once the decision has been made to proceed, you want to minimize time in the patient room. So I'm sure many of you are familiar with these different technologies of electrode caps templates and rapid EEG systems, and there's no doubt that these technologies markedly reduce the time it takes for electrode application, although each of these different modalities does come with their relative pros and cons to consider. Also consider a faster and more efficient alternative to use of collodion. Not only does collodion application take time, but it also involves use of an air hose. And although there is no definitive data published on this, the air hose itself could be a potentially aerosolizing procedure. So particularly if you have a comatose patient that's not expected to be moving around, you might consider a simple head wrap or EC2 paste. And then consider keeping the EEG acquisition machine outside of the room. This would allow basic tech maintenance, like simply restarting a file, to be done without the tech being exposed to the patient. Now, admittedly, there could be a trade-off between EEG safety and the integrity of the video recording, but if simple things like just lifting the blinds in this situation would have given us a much better view of the patient. And of course, when we're in the patient's room, we want to reduce risk of transmission as much as possible. I think by now everyone's quite familiar with the CDC guidelines for appropriate personal protective equipment. But in addition to appropriate PPE for staff and providers entering the room, it's important to make sure that we're masking the patient unless a mask is contraindicated medically for that patient. And this includes our inpatient population. Disposable electrodes should be used if at all possible and if available. And also consider avoiding hyperventilation as a potentially aerosolizing procedure, except in very high yield situations, such as a child with suspected absence epilepsy. And finally, as I mentioned earlier, consider alternatives to collodion to avoid the use of an air hose. I want to say a quick word about equipment maintenance and cleaning. If possible, and if the equipment has to be in the room, then consider covering it with a large plastic bag. But all hard surfaces need to be wiped down at least one time with either isopropyl alcohol or a approved Santa cloth. And if disposable electrodes are not an option, then reusable electrodes need to be disinfected with an approved disinfectant, including dilute bleach solution. And probably most importantly, I think we need to recognize that our EEG technologists really are frontline healthcare workers and are exposed to patients much more so than we are as neurophysiologists. So be aware of staff with high-risk conditions and situations, and I think it's just important to acknowledge the fears and anxieties of our technologists as they really are frontline workers. In closing, I want to mention the COVID-19 resource page that is on the ACNS website, and these resources are updated routinely. In addition, also on the ACNS website is this joint society statement that ACNS was involved in, focusing predominantly on safety of reopening epilepsy monitoring units, and goes into a little bit more detail than what we had time to discuss today. And finally, Dr. Peter Kaplan and colleagues published this nice review in September on specific issues pertaining to recording and interpreting EEGs in COVID-19 patients in the intensive care unit. And with that, I will leave you with my most important safety recommendation, which is, of course, to wash your hands. And we have, I think, about a minute or two for some questions.